Welcome back to the next episode of Endoscopy Essentials, and again with Stefan Seewald. Welcome, Stefan.
Hello.
We have another imaging topic, and I out myself as sort of a non-believer in imaging. So, my name is Thomas. My parents named me after the Apostle Thomas, who was the non-believer. So your task today is to convince me that the endoscopic classification of the pattern of colonic polyps makes sense.
Okay. So I think in Europe anyway, we have the problem a little bit that we are not that good like the Japanese in endoscopic assessment of early neoplasia in the colon. But I think we can catch up and we can only get nice results with imaging. So I think it is good to try to better understand also how we should approach. So what does imaging or endoscopic assessment means? So we first may on the one hand focus on the glandular structures, on the pits. So we see here the opening of the glandulars. These are the typical pits, and then we have the parenchyma, and in the parenchyma we can visualize the vessels.
That's a drawing from the master.
Exactly.
So it's worth a lot of money, probably.
Yes, that's why I use this. So, but I think it's understandable where we have to focus on. So when we look now at these classifications, I think we have to look at the classifications from the point of view, what do they try to classify? So there are classifications only focusing on vascular pattern. There are classifications focusing only on surface pattern, and there are also classification focusing somehow on both. And that is also for our understanding important. So the classification which only focus on the surface pattern is the Kudo classification.
Mm-hmm. Which is the oldest one, maybe?
It is the oldest one,
yes.
Exactly. Yeah. So,
but if there are so many classifications, there's usually something wrong. So we have to decide for very few. Everybody talks about JNET now, right? Is that the classification you're using? Or you using
we are trying to use a JNET classification, but the point of the JNET classification is if you have JNET 2B, the JNET classification is not sufficient, and the assessment of the surface pattern is recommended. And this is very important. We think now JNET classification, that's all, but JNET classification requires additional surface pattern classification of Kudo if you have a lesion of 2B. This is also written in the classification. Okay. And that's why I think when we propose now to use JNET classification, we also have to prepare for the assessment of the surface pattern. And
the good old Kudo.
Yes, this is a very important point.
If it gets too complicated, we usually ask for AI, so maybe in the future somebody else will do the job.
Maybe, yes.
But you will convince me now. Yes, okay.
Okay,
let's
so I think the vascular pattern we can nicely appreciate by NBI. What is now with regard to the surface pattern? And in the original Kudo classification, crystal violet is recommended to use. Crystal violet is an intracellular staining, so it stains the parenchyma, and then you can appreciate the opening of the glandular orifice.
Do you use it? Nobody uses it in the West. Huh?
Actually, we are using crystal violet, but I think another possibility, there are two very important papers. You can also use nowadays vinegar in order to visualize the pits. And I will show you an example. I think my intention is also how can we proceed quickly to get the information. Mm-hmm. And I think crystal violet may be a little bit complicated, but vinegar is more easy for us nowadays to use.
Not spend 10 minutes at every polyp.
Exactly. So this is the Kudo classification. I think we first get always a shock when we see the classification, but actually it's not so complicated. We have these Kudo classifications 3S and 3L. These are the dots here, regular dots, and here are regular lines. Then we have pit pattern 4. We have this dendric form. And then somehow everything which is more irregular, this is then finally Kudo 5. So I think it's not that complicated to understand this classification. It's more complicated to actually visualize the surface pattern. And I would like to show you an example. This is regular colonic mucosa. So here we nicely stained with crystal violet. And this is same patient. Here you see the histopathology, and you nicely can appreciate this regular opening of the colonic mucosa. So this is Kudo 1. It's regular mucosa. Little bubbles, yes.
Okay.
Now we used vinegar, and I think this is also very impressive, especially you get very nice pictures with underwater assessment. So yeah, this is, here you also nicely may appreciate these openings, very regular corresponding biopsy. And these are the two options we have. On the one hand, crystal violet seems to be a little bit more impressive, but vinegar, I think, is really sufficient in order to visualize these
It's a slightly different appearance, so it's less roundish on the right.
Exactly, because the I think vinegar makes a little bit more swelling of the parenchyma, and that's
so there's
why.
a swelling of the little holes.
Exactly.
Ah, okay.
Yeah.
Good.
Okay, so let's come now to the vascular pattern. So the Zano classification, I like this classification very much. It only focuses on the vessels. I don't want to go through now, because nowadays we should use the JNET classification. But as I mentioned before, when it comes here to JNET type 2B, there is already a published paper differentiating between JNET 2B low and 2B high. And these are exactly the cases when you have such a case where you're not sure. In such a case, you additionally should perform the staining either with crystal violet or with vinegar in order to use the Kudo classification.
So most of us are not very familiar with the JNET in daily life, you know, for a normal polyp. Could we go one back and maybe slowly go through the types, what we have to do? So the vessel pattern. So what's your recommendation? You know, assess the vessel separately and not be influenced by any in which class this is. And
I think the most important is to focus first on the vessels by using NBI, and it's also important you should not use vinegar before you have not assessed the vessels. That is very important, and I think what I like to focus on the vessels with regard to the caliber and regularity. And as soon as you have different diameters of vessels, or the structure is irregular, or you have an interruption of vessels, then this is not type 2A anymore. And the most important question nowadays for the practical approach is, can we still go for EMR, or do we have to do an ESD?
Can you please correlate it to pathology? So type 1 is normal.
Type 1 is normal. No, it's type 1. The serrated polyps are also under this. So it's also, you notice somehow it's somehow imperfect, because I think would be better if we have type 0 with regular mucosa, and type 1 is then a serrated adenoma, but there's also already a mix somehow. And then it comes.
Some people saying there's no hyperplastic polyp in the proximal colon. It's all sessile serrated lesion. So who cares?
Actually, yes. I mean, you may perform the Cold-Snare resection, and I think in such a case, the time for the imaging is also limited. You don't need to focus. I think we discussed the problem of larger lesions where we really have to decide between the resection technique.
Exactly, because if it's, you usually can recognize SSL, right?
Exactly.
You take the Cold-Snare.
You're right.
And then you recognize that's probably an adenoma.
Yes.
probably take the hot snare. That's still undecided. But then the question is, where's the limit?
Yeah.
When it's getting ugly?
I think even if it is a serrated adenoma with a white light, you should definitely use NBI, because then you would notice atypical vessels, because in some serrated lesions you may also have atypical vessels, and then this is a red flag for you.
Very few ones, but yes.
Yes, to focus more on the endoscopic assessment. Yes, so what I want to say is now type 2A to B, here it comes then now that the surface pattern are also described in this classification, but I don't know, to be honest.
So tell us again, 2B is what?
2B is already intramucosal high grade dysplasia and cancer potential, also submucosal cancer when you compare it to the histology. So it is not so sure, and here I think the decision has to be made for ESD. But the problem is here, you look, surface pattern are also described, and my personal opinion is you cannot really properly describe the surface pattern only by NBI. And that's why here is the time where you should use vinegar or crystal violet.
So the stop sign for EMR?
Stop sign for EMR, definitely.
Okay.
Yeah. Okay, so what do you need for equipment to be good? You need a good magnification endoscope. I also recommend the 1200 series from Olympus. Then I think indigo carmine is also not bad. Sometimes to see the margin of the lesion, and it's easy and cheap to use. And then, first of all, you should use NBI or an equivalent from other companies. And then you should have crystal violet or vinegar available.
So mostly acetic acid, huh?
Acetic acid, yes.
For practical reasons.
Exactly.
Yes. Okay.
Yes. Okay, so I would like to show you a case. This is a patient with a non-granular lesion. And when we use now the different imaging with white light and TXI, you will notice already that this polyp shows different areas. In some areas, the polyp looks more reddish here.
Deadly.
And this can be nicely enhanced by TXI. And I think the discussion...
So this is the ugly, it's slightly depressed as well.
Exactly, so...
That's the ugly area.
Even this is in the colon ascendens, we have to discuss if we better should perform an ESD in this case. We can notice here 3 areas which are different from the other areas. And now, this is again indigo carmine, which is cheap and quick. So in this case, we did also now underwater zoom NBI, and what I'm doing now is I'm focusing on these different areas of the polyp. So in the upper part there is this previous reddish area, and here you notice we still have regularity, but somehow some vessels are also cut. And when we go here in the middle of the polyp, then we have more regularity, and there are the vessels still completely follow the mucosal pads. And when we go here in this second reddish area, when we use NBI zoom, you nicely appreciate that the vessels are also getting here a little bit more irregular. So when we do, or when we follow now this JNET classification, I would classify this reddish part at JNET 2B, low, and this central area at with JNET 2A, more regular. And again, the other reddish area in front is also more JNET 2B, low. Okay.
Just by the vessels?
By the vessels, yes. So from the JNET classification now, you should also focus on the surface pattern and use Kudo classification. So in this case, we finally did both. First, I would like to show you crystal violet. And this is now first the central area. And here, this is very nice. Always when you do imaging, we do this underwater. You have it more sharp and more precise. Again, here underwater, focusing on the central area. And we can nicely...
You're not worried by the depression per se?
A little bit, but I think, interestingly, this depressed part was more...
looks regular.
More looks regular. So here nicely we can see this type 4 pits. This is a picture here. So type 4 pits in this central area. Now we are focusing on the reddish area. We also do underwater with magnification. And here you nicely appreciate these roundish pits, still regular, but I think you may nicely appreciate there's a difference to the other areas. And here we classified this as Kudo type 3S. So round, maybe also Kudo type 3L. It's a little bit, some are roundish, some are more long.
Wow.
Okay, now I would like to demonstrate you now the same with vinegar. Here we have the central area, and this is the area in front, and I think we can also nicely read the difference in the pits of these two areas. So here we have more the Kudo type 3S pit pattern in this area. And when we go to the central part, here in the lower part of the imaging, you nicely see the Kudo type 4. In this case, I think the type 4 pit pattern you better can visualize by vinegar. So again, here type 4, and here we have type 3. Again, selective this area and this area. Okay, now you will ask me, what is the consequence?
Yes, of course.
So in this case, we performed an ESD.
You did?
And now the question comes to the pathologist, are there differences in these areas? And there are differences, interestingly. So in the area of this reddish mucosa, we have focal high-grade dysplasia. And we tried now to compare the histopathological pictures with the imaging, and you will notice here we have these small openings only in the histology. And when we go now to this side, where we have no high-grade dysplasia, you nicely appreciate here the openings of the glands are larger, and this is corresponding to type 4 Kudo.
Okay, so
I know you want to say the consequences anyway, resection, but what I want to show is that we should better focus, and we try to do a proper endoscopic assessment, and we will have more complicated lesions than this lesion, where the decision is more complicated. But I think what I wanted to show is that we can do JNET, but we can also do Kudo. And to conclude this again, JNET doesn't mean that we don't need Kudo, and especially in such lesions between where we have 2B JNET, we should perform also an assessment of the surface pattern.
Well, with regards to consequences, this is a slightly different topic, admittedly, because we are really focused on imaging today in this podcast. Of course, you could say, if I take the head of Michael Burke, he says, no issue, we do EMR, high grade, who cares? And Jeremy Schack, if I take his head, said, oh, thanks God we have done ESD. So, still open question. But we want to learn imaging.
Yes, but I prepared another case for
Yes,
you
of course.
where this has more influence on the therapeutic consequence. So,
but it looked a bit ugly, the whole polyp, huh?
Exactly.
And it might have been difficult to resect by EMR, so I don't know how lifting was. So these are other factors, technical factors for resection.
Yes. Yeah. Okay, so this is a second case now, and this is a more ugly lesion in the rectum.
Yes.
As you can see here, this polyp looks very suspicious for cancer, and already in the biopsy, intramucosal cancer was detected. So yes, in such a situation, we first use TXI. We can better appreciate the more suspicious area of this polyp. Then we use indigo carmine. Gives us again also important information of the area of the most.
And you have these whitish dots in the surrounding.
Exactly, yes. Yeah? Very suspicious for deeper submucosal invasion. And then we use NBI, also with this 1200 series colonoscope. And very nicely, the most suspicious area appear more silver with this endoscope. So we are tracing here this polyp.
It makes the ugly areas more beautiful.
Exactly, yes.
Imaging, but they're still ugly.
So in this case, we used crystal violet. I will show you the images again later. So we put this underwater, and in this situation, or in this polyp, we also have two areas. One is the central area here, and what you nicely appreciate, we can see nicely the opening of the pits. So we can definitely visualize these pits, and for sure, this looks like Kudo type 5N, 5I in this case. So this is really a case highly suspicious for deep submucosal invasion. Okay, let's go back now to the imaging. Now the question is, this lesion is in the rectum, and even we have signs of submucosal invasion. The question is, can we still go for an endoscopic resection? But what does endoscopic resection mean? Either we would resect this polyp by ESD, or we would proceed for endoscopic intermuscular dissection, because then we would be sure that we have also part of the muscle, and we have the higher chance of getting an R0 resection. So with regard to the endoscopic assessment of this polyp, what we do is we test the non-extension sign. This is originally described for the stomach. So we insufflate air, and what you may see here, that this polyp here in this part, even this looks more ugly, still extends during air insufflation. However, here in this area, you have a non-extension sign. So with regard to that, this area is more suspicious for submucosal deep invasion. But yes, I think when we look now again here with TXI, indigo carmine, and also with NBI, we can notice we have different imaging areas. So let's say here in the front it looks still regular somehow, but when we do JNET at the beginning, we also see here the vessels are getting irregular and cut. They are not connected anymore, but the surface patterns still are somehow regular. When we trace now this polyp here, I show you again this special demarcation line within the polyp. And I think here in this area, when we use JNET classification, I would rather say this is JNET 2B high, because here it looks still regular, but it's also getting amorphous, so it tends to be type 3. And then when we follow here at the proximal part of the lesion, this is definitely type 3, because we have here somehow avascular areas as well. And so I think, as we said at the beginning, this polyp is highly suspicious for deep submucosal cancer. Now, in this case, we performed also crystal violet staining. So in this part at the left side, we still have pits of Kudo type 4, but here in this area, it's definitely Kudo type 5A to 5N. Yes, the question is now, what would you do in such a case?
Well, I think honestly, if you have a proven cancer and you decide for endoscopic resection, you should probably ask yourself whether ESD could be a systematic undertreatment. So why not going for the deepest distal rectum we have, which is endoscopic intramuscular dissection, just to be sure. That's a similar argument which the ESD people use in their battles against EMR. You know, we have a certain risk and we want to avoid this and we want to do the maximum.
Yes.
And the same may apply here.
I fully agree. And I think also this endoscopic intramuscular dissection is still a method where we don't touch the outside of the rectum. So we don't deprive the patient from any potential surgical treatment. So
probably not. There's limited experience of patients secondary operated, but it doesn't seem to be a big obstacle.
Exactly. So we did endoscopic intramuscular dissection, and here you may appreciate how we cut the circular muscle. So we kept the longitudinal muscle, and this is the final result. Here in this area, you appreciate here's still circular muscle. Here we went into the intermuscular space, and here we kept the longitudinal fibers. And this is the resected specimen. Here you nicely appreciate the muscle. And now we come to the result. This is already deep submucosal invasion, as we expected before, but there is no lymphovascular invasion. And thanks to our decision to perform an AID, we could achieve an R0 resection. We could discuss now how to proceed with the patient. What I want to show you, if you remember, we had two different areas of this polyp in the front. So this is the area here in front.
The more bulky one, left side in the picture?
The left side, exactly. So here we still have an area of high-grade dysplasia, where we found the Kudo type 4 pattern. And in the central area, there we have this
depressed area.
Depressed area is the deep submucosal cancer, exactly the area where we had the Kudo 5I and 5N pattern.
And it looked more infiltrating, if you want it by simple terms.
Exactly.
Yeah. Okay. Good. So I think it was for me, sometimes a bit painful exercise. But even if you can say, okay, the practical consequences, you can draw on much simpler criteria, perhaps. I think it's never wrong to go in depth and try your brain, your eyes, how that looks like, and whatever consequences you draw at the end. I think it makes you smarter to look better. So you have convinced me a little bit.
I'm happy.
Thank you.
Okay.
Thank you, Stefan.
Thank you.